Hi.
So the other faculties are just joining us. Give us 2 more minutes, they'll join back.
Hello.
Due to the difference in the time zone, two of our faculties are driving back. They'll join in next 2 minutes.
Hi, Saurabh.
Hi, how are you?
Yeah, good, thanks. I didn't realize I was in this meeting. What session is this? I just had a phone call.
This is about injectates and hemostasis.
Oh, okay.
So we'll just shoot some questions, discuss.
Is there anyone else in the room there?
Michelle Kahela was going to join,
Uh-huh.
supposedly. So, well, I'll check with the organizers what the status is.
Okay.
Michelle is joining us, Dr. Michelle, and also
Yeah,
Dr.
so
Pradeep Bhandari is
I
joining
was
us.
telling the audience that once you do Z4M, don't expect your diabetic leg to go.
All right. Well, I suppose I could share my screen here, if that's cool. Yeah, 1 second.
Hi, Michelle.
Hi,
How you
how
doing?
are you?
I'm good, good. You well? I haven't
I'm
seen you for a
okay.
long
What
time.
about you?
Yeah, I'm good, good. You know that I'm in Australia now.
In Austria?
Australia.
Australia?
Yeah,
Wow.
I moved 2 years ago from Nottingham to Perth.
You're a very smart man. It's a beautiful country.
I didn't plan though for the coronavirus or nor for the Brexit.
Maybe I should join you.
You're welcome.
Thank you.
Hi, Dr. Kahela, how are you? Yeah.
How you doing?
Yeah, I'm back in India now.
You have an amazing suit.
Yeah,
That's
right.
right.
All the way from that,
So we all are here, so we can join.
All right. Okay.
what
So
is
should I
the
start sharing my screen because I have a little thing here to ask questions? If you'll enable me, because you have disabled me from screen sharing.
Hi guys, it's Pradeep here. I've just joined you as well.
How
Hi,
you
hi.
doing?
Thank you.
Nice to see you, Michelle, after a long time.
I know. Great to see you. I love your outfit.
And it's 30 degrees in England.
I see.
Good. All right. Okay. So, if the organizers are okay, should we start the session?
Sure, sir. We can start.
Okay, cool. So, hi, good evening, everyone. I'm Saurabh Mukewar, and we have this breakout session on injectates and hemostatic agents. And we have a stellar faculty here, Dr. Krish Raghunath, Dr. Michelle Kahela, and Dr. Pradeep Bhandari, who've joined us from different parts of the world. We have Australia, America, and United Kingdom, and I'm sitting here in India. So great to have an international session here. So I'm just going to ask, there are a lot of injectates available out there and several hemostatic agents as well. There's a paucity of great data. So I'd like to ask all the panelists as to what sort of qualities do you look for when you're evaluating an injectate agent? So, Dr. Bhandari, anything?
Hi.
Yeah.
Yeah, oh, thanks. Yeah. So listen, thanks to Amol and everyone for organizing such a nice meeting. I think injecting solution and injecting skills are two very crucial part of all advanced resections. Uh, the issue about injecting solution is when you are in your early phase of resection, you want the most viscous solution, you want blue solution, you want norepinephrine, you want everything. Uh, as your learning curve goes higher and higher up your learning curve, you begin to come down again and you start using saline, you use very little dye or no dye, and you stop using epinephrine in it. So the answer to this question will depend on personal preferences rather than what is exactly required, because I don't think we have enough data to say this solution is better than that solution. The issue, however, is that in some countries it is difficult to make your own solution, and their ready-made solutions. Now we have in US various solutions like Orize gel and Eleview become very popular, and rightly so because they are ready-made, very viscous. You inject, you cut, you don't have to think.
Okay.
Whereas in UK we use Geliffusion with epinephrine and indigo carmine in it.
Okay. So what I'll do is I'll just go through different lesions and ask each of you what your choice of injectate would be. So say we are looking at a polyp less than 2 centimeters and you want to lift and cut probably on block. So Dr. Raghunath, what would be your preferred agent?
It's
Be happy with that?
interesting. Sorry, it looks quite small. I would just put in a cold snare and resect it looking at it.
Right.
I don't think I would even attempt to put in any injections for this, to be honest. But
Yeah.
for my view in the colon for resections, either saline or gel fusion is good enough to do standard resections with snare resections.
Okay. And say, Dr. Kahela, if this is a slightly laterally spreading polyp, a little 2 centimeters, and say we are doing a piecemeal EMR, how would you, in terms of injected solutions, would you go try something else, or you'd be happy with NS and methylene
No,
blue?
I think I would like a nice lift and something that will be sustained. And as you know, in the United States, we're very spoiled. We don't have to make our own mix. So I will probably use an Orize injection right here. I will have a nice lift with the blue so I can see the margin. That would be probably my way to at this stage.
Right. And again, going forward, EMR of a large laterally spreading lesion.
Yeah.
Something
I mean,
similar.
that's definitely a nice lift. That would be an Orize without any question.
Yeah.
I would agree with you. I think if you're going to do EMR of such a large lesion, using Orize or LFU type of solution can really make it very efficient.
Yeah. And say we're doing ESD. You early in the learning curve, you want to do a smaller lesion for ESD.
I mean, I actually recommend to start with small lesion when you start doing ESD. You have to, to master the technique, obviously, in a big lab first. And this is the kind of lesion that actually I will give to my advanced fellow while they're getting trained. I want him to start with small lesion. I don't want him to start with the Grand Canyon lesion at the worst case.
Yeah. So for ESD as well, you're happy with Orize, basically, as you mentioned earlier. Okay. Now the question really is, I mean, Orize is expensive and probably not widely available for other parts of the world where these expensive, fancy solutions aren't available. Do you have any alternative suggestions? Say, in Australia or UK or
I think it's a great question. In the United States, before Orize, I'm gonna be honest, I wasn't very satisfied with whatever was on the market. So what I used to do, I used to make a mix of normal saline, a mix with a little bit of epinephrine, and mix with a little bit of hyaluronic acid. And actually, interestingly, hyaluronic acid can be found in eye drops. So what I used to do, I used to go to the pharmacy and pick up a lot of those eye drops bottle, and then I will make my own mix. They didn't understand what I was doing with this eye drop bottle. They thought I had a lot of problem in my eyes. But in reality, what I was doing, I was making my own homemade Orize.
Yeah, no, I hear you.
I see, Michelle, I get a lot of problem because I'm not as good as you with ESD. I take 3-4 hours looking at the screen. My eyes get very dry. So I put that hyaluronic acid in my own eyes.
Serves both purposes.
Perfect for the patient and for you. Double impact.
I agree. There is always an issue with the solutions. The more thicker and jellier it becomes, the more expensive it becomes. I don't know why. And we even tended to mix it a little bit of the hyaluronic acid with saline and inject it. But, I don't think gel fusion is a good intermediate for all these things. And it is inexpensive and it is universally available in almost any part of the world. And that should be good enough to resect using that. But in difficult situations, in areas where it is a very thin wall and things, then having it, like for example esophagus, then it'd be nice to have the ones which has got a bit more viscosity and it stays longer.
Yeah. And for POEM, we obviously use methylene blue and normal saline. Has anybody used other agents? Any for the utility of these agents? Probably not, right?
I think the
like,
point is it's because you don't want too much thick fluid there, and you want something just a little bit lift, and once you go in, so that you see a subcutaneous tissue, areolar tissue there, and keep clearing and going. You don't want something which keeps bubbling inside with your diathermy and so on. So saline is perfect for poem and any tunneling techniques, and I think it's what you are going to do, and you choose your injected to what you're going to do. And for poem, as you say, saline seems to be the best one for it.
Right, right. Okay. So we'll just go through some of the agents out there and your thoughts on these. So normal saline, certainly not in the US where you have fancier agents available. Any cases you'd still be okay with normal saline? Of course, poem as we discussed. Probably smaller lesions, I guess, right?
yeah, I mean, whenever you don't need a major lift, it's a good solution. Like a small little polyp, why not?
Yeah, yeah.
Also, if you're doing ESD and if you are using one of these knives where you have a water jet to help you inject, like hybrid knife or any knife which injects through a water jet, I think it's a very good solution to go through, because a very quick, rapid injection, rapid cut, it's no problem.
Right. Okay. Anybody uses dextrose water at all? Well, these are just the agents out there. So that in the interest of the audience who are young out there figuring out to choose amongst these, I suppose.
I think the 10% dextrose has been used in the past as something more viscous than the normal saline, but I'm not sure it is. Everyone is universally it's being used now.
Yeah. How about glycerol? Have you guys used glycerol?
I mean, I've seen some Asian that still like glycerol because it's very dense and it doesn't get absorbed very well. So I've actually seen quite a few Asians still using glycerol.
Yeah.
I have a bottle which I bought from Boots in those days. When we didn't have these things in those days in the UK, we need to find ways and means of doing it. So I still have a bottle of from the Boots what I bought for the ESDs. But again, that's a bit archaic now.
Ah, okay. About hydroxyethyl starch. So this is there's some data to suggest it's pretty good and lasts pretty long. Have you guys used it?
So actually, Norio Fukami is a big fan of that solution. So when he's traveling, and especially in the United States and doing cases, since before ORISE, what he used to do, he used to make his own mix with the starch, and it give a decent raise. Actually, it's a very nice alternative if you don't have access to ORISE, LAView or stuff like that.
Yeah. Okay. All right. The Gelaffusion. So that's more widely available, I guess, more popular amongst other countries. Yeah.
Yeah, it's universally available and it's not expensive, and you can easily get it and use it, and it does a pretty decent job.
So in your practice in Australia, and when you have to do an ESD, would you use Gelaffusion or no?
This is the standard one what we are using now. Yeah.
This is what is your standard right now. Okay. And the hyaluronic acid, which Dr. Kahela pointed out. Interesting. I think it's another alternative. And same thing with gentile eye drops, which is what the contents are. So there's good evidence to support the use of this with longer duration of lift. I guess any of the studies haven't shown improvement in complication rates or this, but I suppose lesser injections and lower procedure times with these. Okay, I think we did allude to LAView and ORISE gel, which we are excited to have in India, I think in next year or so. And I think the US task force has also recommended using these gels for larger than 2 centimeter lesions for everyone to know. All right. So any choice, indigo carmine, methylene blue, when you're not using ORISE?
Don't use methylene blue, use indigo carmine, because methylene blue can stain quite deep and it can even stain muscle. So you can still cut superficially the muscle and you might still not know that you cut the muscle fiber superficially. So I prefer using indigo carmine. It can be very easily washed away.
Yeah, indigo carmine is my preferred as well, because it doesn't stain, and it's non-toxic, and as Pradeep said, it doesn't stain it too much and go deep. So indigo carmine is it's a good dye to mix up and use.
Yeah. Okay. But for poem, we use methylene blue. But for ESD, you would suggest indigo carmine or methylene blue, basically, right? Okay, cool.
Why you use methylene blue? Is indigo carmine not available?
I mean,
Where?
it's much more difficult to find indigo carmine stays in methylene blue. For some reason, the distributor of indigo carmine has very, very few, storage. But
Okay.
methylene blue, we can find plenty.
Yeah. Yeah. Because again, we are used to methylene blue. This is actually news to me as a person personally as well, that you prefer indigo carmine over methylene blue. So thank you. That's something I learned today. All right. So let's switch gears. Let's talk about hemostatic agents. And I suppose most of the doctors attending are also advanced endoscopists or gastroenterologists using these agents and other indications beyond third space endoscopy. So I suppose we could extend the discussion beyond that as well. So if you're having an active bleeder, just for the sake of learners, what would be your dose for epinephrine?
I mean, a safe dosage is 1 to 10,000 dilution.
Right.
There are people that like to do ESD with 1 to 100,000 dilution to prevent a massive vasospasm so that you don't have delayed bleeding after. So I think, you need to decide when you want to do the 10,000 versus the 100,000 dilution, basically.
Yeah. And sorry, go ahead.
No, I was going to say that's a very good point. I used to use 1 in 10,000, but recently we changed it, especially for right colonic. Some of our patients started getting ischemic pain afterwards, and that can be very easily misunderstood as perforation or post-polypectomy syndrome, but it was all related to epinephrine. Ever since we stopped using that or really diluted it, that phenomenon stopped. But only in right colon. I haven't seen ever in the left colon. I don't know why.
I think it's a very valid point about ischemia, because again, it depends on what you are using it for. If you are using it for an active bleeder, then you need a 1 in 10,000 if you want to stop it.
Yeah.
If you're using it for as your EMR or ESD mix, then you need to have it in 1 in 100,000, 1 in 200,000. But in my view, I have had one patient who developed an EMI after having a large resection in the rectum. In fact, it was reported in GIE. He is known to have ischemic heart disease, but he never had any problems with angina. But after the procedure, half an hour later, he complained of chest pain, and he had a MI. So you need to be a bit careful when you're using a high volume of epinephrine. One, you can have a false sense that everything is fine, and you can have delayed bleeding. If you want to have a clear field, then you can have it in higher dilution. But if you want to stop it, you need a higher concentration. But it can give you a false sense if you're using it as a mixture in your EMR or ESD. And also be aware that ischemia can happen, especially in the right colon. And once we had a patient who went on to have a resection, and they found in the pathology specimen a lot of ischemia in the cecum. And probably this is because of the injection. And as I said, in case of MI, after a large resection of the rectum, with using epinephrine injection along with the injective.
Okay, no, thank you. And this is, say, for active bleeders. Any preference in terms of the needle that you use? What, 23 gauge, or anything routine?
Yeah, I mean, you can always get away with the 20 gauge. It's very rare to need to use 19 gauge needle. So yeah, 20 is perfect.
Okay. So Gestalt, when there's an active bleeder, I mean, say, not even extrapolating this outside an ESD space, uh, what, where do you sort of, as for the beginners and the GI fellows out there, how much would you want to inject? Say 1:10,000 epinephrine when there's an active bleed.
I mean, just a few cc on the side of the vessel. You don't want to like we're talking about cause ischemia, enough to decrease the the velocity of the bleed, or enough to control the bleed, enough to add another therapy. I mean, this is just something that will temporize you and allow you to act upon after that.
Right. Okay, I think we did allude to the cardiac issue.
Yeah.
So if for bleeding prophylaxis in ESD and EMR, do you use it? I think we did discuss that the concentration is much lower, 1:100,000 or so. What's your preferred concentration? Let's start with that. If you had to use it as a prophylactic agent during the ESD.
I mean, definitely, if you want to add it to your ESD solution, it shouldn't be more than 100 to 1,000. I mean, you don't want to do the 10,000. Like we were talking about, some patient will be bad about it. Plus, remember, you don't want to completely have. Yeah, I'm sorry. We don't want to have did you hear me?
Yes, sorry, I apologize.
Yeah.
I'm sure what happened there. We don't want to have a complete elimination of any kind of oozing, because otherwise you will have a big problem in terms of delayed bleeding. So if you eradicate all the bleeding, you're going to have a much higher rate of delayed bleeding. So the 100,000 dilution allow you to still control major bleed, but at the same time, it doesn't give you a strong vasospasm. So those vessels, you can take care of them so you don't have delayed bleeding later. That's what I was trying to say.
Okay, sorry for the disturbance. And in terms of choice, and say if you're doing ESD in the esophagus, stomach, duodenum, colon, rectum. So where would you use epinephrine, 1:100,000? Or in which cases? Say, I think, right, colon or duodenum, which is very vascular, for instance, right? So just your personal preferences and choices. When do you use it and when do you not?
I like it in the stomach. I really, the stomach is typically well vascularized. You don't have fear of ischemia over there. It's very rare unless you have severe vascular paths. I actually avoid it completely in the colon, and I tend to avoid also for large ESD in the esophagus. So I don't know if you remember the very first lecture of Inoue about POEM. He actually doesn't use epinephrine at all, because one of his biggest fear when he does a tunnel is actually inducing necrosis of that epithelium. And I truly believe that is a very rare complication, but a potential complication. So I mainly use it in the stomach and avoid it into the esophagus and in the colon.
Yeah.
That's a very valid point about the mucosal necrosis using adrenaline, and I have never used it for POEM. For when I do large resections, then I normally have two bags, one with and one without. So I start off without, and I keep resecting. And if there's any oozing, then I just inject a little bit of one with some adrenaline just to keep the field clear, and then keep resecting. So having these two bags gives you a choice of what to use as you do, and start off without any adrenaline. And if you need to keep the field clear, then you can use one of the injections. You can use it with a bit of adrenaline to keep the field clear. I think that's a reasonable balance to do.
Okay. Thank you. All right. Let's see. How about thrombin? There's a lot of excitement about thrombin in the last few years. Well, not limiting ourselves to ESD, but do you guys use it at all for, say, gastric varices? Now there's some randomized trial data showing it's equally effective as glue. Glue is sort of newer thing for the US gastroenterologists, but certainly the rest of the world uses glue more often. So, guys, any experience with this, with thrombin?
I mean, the problem of using thrombin, especially the homemade solutions, the one that comes already pre-made, your field of vision is dramatically affected after that. Well, once you use this, you have this coating, white coating that cover everything. So we keep thrombin as the last resort. Like when you really, you've injected, you've tried to clip, it's still oozing, it seemed to be diffused. That is really our last resort. I may have used it in 2 to 3 patients during a severe bleeding that have POEM. That's it.
Okay. Now, so now you do ESD and there's a lot of active bleed, and if you're unable to control, do you spray epinephrine sometimes just on the surface? So the more difficult ones, of course, unless
yeah, I actually try to go at the side of the bleeding area, and I inject epinephrine to try to at least limit the bleeding, because the idea is always the same. You need to find the vessel that is responsible. So, spraying over the lesion, it doesn't really work well, especially if you have a lot of blood that is pouring out. So it's not gonna, it would be very, very difficult that it works unless you spray a lot. But if you use the edge of the area that is bleeding and you gently inject there, you may be able to decrease the bleeding enough to actually identify where is the vessel that is bleeding. And then what I always say to my fellow is, you got to really stay as calm as possible and use that cap, because the cap, after injecting epinephrine, is your best friend to capture the area where the vessel is, and then tamponade this gently before coagulating it. That's a very important technique if you do third space that you need to master. Is like, gently use that cap in the area of the bleeding to kind of tamponade and find the vessel and coagulate it.
Yeah.
Cap and water jet, a combination of the both.
Yes.
Helps, because once you get the cap and come back and then it comes up, then you put the water jet, you know exactly where it is coming from.
Absolutely. Yes. The water jet is actually in action at that moment. Absolutely.
Right. Okay. So glue, have you ever had to use the sort of glue when you're doing ESD or so?
I have not used glue during ESD.
No, not used to.
Best to avoid that. I think glue is just for gastric varices and nowhere else.
Right. Okay. All right. So, and how about fibrin glue? There's some. Is there? Have you guys used fibrin glue at all as a hemostatic agent?
Not so much for bleeding. I've used it for other things like fistula and stuff like that, but not so much for bleeding.
Yeah. So even if okay, and I guess I'm just gonna quickly go through this the last slide here. So sclerotherapy, for all of you who probably been times using sclerotherapy for EVL. Well, not I mean esophageal varices.
We all remember how delayed was the United States to adopt cyanoacrylate in varices. So they were still using sclerotherapy until maybe 4 or 5 years ago. And that is the best instrument to create severe ulceration that will bleed, that will provoke delayed bleeding. So this is something that as European, I was shocked to see. They took us so much time to adopt, cyanoacrylate. It was a shock for me.
Yeah, I mean, sometimes you have post EVL bleeders. What's your take on those cases? It's scarred mucosa in the esophagus, and there's ulceration, it's bleeding.
Sclerotherapy will work at the moment. The problem is the delayed ulceration. That's the problem. Yeah. So you're creating another problem later. So you only temporize, and I think that's the biggest problem of sclerotherapy. I have completely abandoned it in my practice.
Yeah. So what's your take on management of these post, say, EVL ulcer bleeds?
Yeah.
Short of a LR-Danis stent, is there anything else that you try endoscopically to stop?
I mean, those are the one when you have to start thinking about mechanical closure. Those are the one, because you have a defect, you have a bleeding, you need something that can take care of both situations. And then this is where clipping play actually a very big role. Those are the one that you have to find the appropriate clip to use. And if they're really deep, you know what? We've placed Ovesco in some of those lesions.
Mm-hmm.
I think, this is where you also need to think about alternatives. You need to get a tips done, and you don't need to go to a stage where it is repeatedly bleeding and try and get an early tips done. So it's just not locally managing it and managing the whole pathology.
Yeah, yeah, fair enough.
Yeah, I mean, if we're talking about viruses, I mean, absolutely. At some point, you have to start thinking about, another therapy such as tips. Absolutely.
Okay, great. All right, so I think we'll just wrap up the session. I think we started a little late today, but welcome to have any other comments that you have in terms of your advice. Truly appreciate all three of you joining in from different parts of the world and all your insightful comments. Yeah.
I think what we really discussed about is Purostat in the setting, and Pradeep has done a lot of work in that. And I think that's, if at all anything we need to discuss, that is the one I would be thinking about discussing here, because I think, Pradeep, what's your current data on that?
Yeah, you're right. I mean, we've got a lot of experience. It's been around for 5 years, 6 years in Europe. It's already there in Australia now, and they've gone for an FDA approval in US, and then it'll be coming to India as well. It's a very nice, clear hemostatic agent, very effective in settings like ESD, sphincterotomy bleeding, radiation proctitis, tumor bleeds, very thick, transparent gel you apply, and within 30 to 60 seconds, you can see the bleed control in front of you. The only type of bleed it doesn't work is spurters. Arterial spurt, it will never work, so don't waste your time. All other bleeds, it's a very nice agent to use.
I think it's the type of things. What I use is, you do a resection and there's a little bit of bleed oozing here and there, and then you apply, and that's perfect. So, in fact, a lot of my Barrett's EMRs, my wide resections, also I'm using it post resection, because there's always a little bit of a ooze here and there. And the duodenum, you can use it, and it's quite good in the colon. So wherever you're doing wide resection, you can use it once you finish the resection, when there is a little bit of ooze here and there in the edges.
So I apologize for that. I missed the part. Which agent are we talking about? Because it's not available in India. So
Purostat. Purostat.
Fluorostat.
It's called Purostat. Purastat.
Purostat.
Yeah.
Okay, thank you.
Purostat. Yeah. I think there is a similar agent. Nagy always tells me there is something in India, a gel like that.
Is it
I don't know what it is. No, there's a gel, transparent gel. Nagy says that they have, the surgeons use it, and they can use it endoscopically, but it's not very popular.
I think this is probably the fibrin sealant. I don't know if this is the one, because this one is available in India. Probably.
It's completely. But don't worry, Purostat's coming to India very soon.
Okay, good. Look forward to it.
Pradeep is bringing it in India now.
Okay.
Yeah.
All right. Good. Okay. All right. Good. Thank you. Thank you for that.
Thanks a lot. Nice to see you guys. Have fun. Yeah. Bye.
Hopefully we get to see you guys in person in future meetings.
Hopefully.
Craziness and okay.
Bye, guys. Bye.
Thanks, Dr. Bhandari, and thanks, Krish. Thank you. Bye-bye.